Welcome to On Point. Let me tell you about today's guest. Dr. John W. Devlin is a critical care pharmacist and research scientist in the Division of Pulmonary and Critical Care Medicine at Brigham and Women's Hospital in Boston, as a professor of pharmacy at Northeastern University. His federally funded research program focused on the detection, prevention, and treatment of delirium and disruptive sleep in the ICU has generated nearly $2 million in funding and more than 200 publications. He is a member of the editorial boards of the Critical Care Medicine and Pharmacotherapy, a past president of the American Delirium Society, and chaired the Society of Critical Care Medicine's 218 Pain, Agitation, Delirium, Immobility, and Disruptive Sleep International Clinical Practice Guidelines. He's a world-renowned medical scientist, and I consider him a good friend. And he's on point. Well, thank you for joining me today on Point. And as you know from the introduction that I just gave, this is a special show. Every show has its own special quality to it with the different people we talk to, different places we visit. But this one is special because, hey, one reason why it's special is because our guest is in Boston, Mass. And besides that, not only is he a nationally and maybe world-renowned medical scientist, but I count him as a very, very good friend. And so it's with a lot of pleasure that I get to introduce to you in person Dr. John Devlin. John, thank you very much for being with me on Point.
And it's an honor to be with you today. I'm really glad we can make this work.
I am too. You are a very, very busy guy, being there at Brigham and Women's Hospital in Boston, Massachusetts, and I appreciate the time that you've snuck away from your busy day to be with us. I've told the folks at home a little bit about your background, but I caught up with you because of my involvement at Johns Hopkins. I was doing a lot of, and still am doing a lot of volunteer work at Johns Hopkins in various programs and committees there. And one thing led to another about 3 years ago, and or maybe 4 years ago now, and I got involved with the PFAC, the Patient Family Advisory Committee, and met a lot of people and doctors and nurses and stuff. And the next thing I know, I'm being told about this special study that you were in charge of. And then I find myself attending online meetings with all these great doctors and scientists and everything. And, and my background is, if you will allow me, just education. I've got my master's and certificate advanced study in educational matters. But yet you guys wanted me to be on this committee of about 50 people just so I could give the perspective of a patient, how it is to be a patient in the ICU. And my dear late wife was also a patient in ICU at Johns Hopkins. So I had both of those components and was with you on the committee. And then after meeting online with you guys for what seemed to be an eternity, one day you told me, Ken, we're going to be meeting in person. And I said, where are we meeting, John? And you said, Honolulu. And I said, yeah, right. Yeah, tell me another one. And sure enough, the next thing I know, I'm standing out there under a palm tree and talking to you and going out for an Italian dinner in downtown Honolulu. So that's quite another story for a completely different show. But anyway, so everybody at home, that's another reason why I'm thrilled to have this guy here, because not only is he an expert in his field, all in caps, underlined in big red letters, but I consider him, like I said, a great friend. So anyway, John, to start the meat of this show, to get into the heart of it, maybe we could just start about this journey that you've had. You've been a delirium researcher. You've been in the ICU, and it's been for well over 20 years now. You've done all this ICU research, and COVID research in the ICU. So let's get into this massive journey that you've been on in medical research.
Yeah, no, thanks very much. And I think this is a story for everybody, and it's kind of a story about the way the critical care, intensive care unit field has moved really over the last 25 years. And if you were an ICU patient 25 years ago and were admitted to your local hospital or a larger teaching institution, and you were sick, say with a bad pneumonia or with sepsis or any other serious condition that required an ICU admission, we would obviously generally put you on a breathing machine, and we would really heavily sedate you because we sort of felt, well, we don't want patients to remember anything about their ICU stay. We want them to be safe. We want them just to be really protected and not have memories of any bad things. Families weren't really allowed to visit very much, maybe just for a few minutes each day. And, it was a very focused sort of, the ICU physician knew everything. And we were building an ICU team with pharmacists, physiotherapists, nurses, respiratory therapists. But that was kind of the reality we lived in. And what we realized about 20 years ago was how dangerous a model this is. And we realized that when we really put people into, you've probably heard the term like medically induced coma, how dangerous a state that is. Now, there's a very, very few patients that really actually need that to be, some of our really sick COVID patients we've had to do that with. But for most ICU patients, they need to be a little sedated. We want to treat their pain. We want them to be comfortable on the breathing machine, but we keep our patients much, much more awake. Because what we realize is when we were keeping patients more awake, they were actually getting confused. Because when someone's really, really in a coma, we have no idea what's going on in their brain, right? So once we started keeping our patients more wakeful, and where we could interact with them and ask them questions, and they would nod their head, yes or no if they're in pain, for example, they would recognize their family. But we would see that they would be acutely confused, and we realized this is delirium. And delirium is an acute state. So, someone that has Alzheimer's disease has dementia. It has a dementia, right? And that's sort of a sad trajectory of worsening cognitive function. So that means how they think, how they can function, both physically and mentally. And unfortunately, many people have to end up in a nursing home with Alzheimer's disease. What happens with delirium is it's where people were playing cards, driving, engaging, with their family, working at their job, driving, and they get suddenly critically ill, again, from, say, a serious infection or a major surgery, and they suddenly are acutely confused. They don't recognize their family members. They don't know where they are. They're not really attentive. Sometimes they can become very, very fearful and afraid with hallucinations. They don't sleep very well. And so this is something that is, an acute event that happens when people become really sick. And what we want to do is we want to recognize that. So I've helped work with a lot of talented people across the United States and the world to identify ways to recognize delirium in our patients. And because there's things that we could do, like waking people up, giving them less drugs like Valium-like drugs, engaging them with their family, getting them more awake, and sometimes standing and moving in the ICU even while they're on the breathing machine. These things can all help reduce delirium. And so there's a lot of things we can do. And so I've worked with with an interprofessional team, and we've developed what we call the Icu Liberation Bundle. And this is a whole bunch of different interventions, both with medications, but primarily without medications. We're actually trying to give less medications. And our whole goal is that patients that are critically ill, like you experience at Johns Hopkins and your wife experienced at Johns Hopkins, when you were in the intensive care unit there, can have a better transition out of the ICU And, all anybody who ends up in the ICU really wants is they want to get back to the life they had before they became really sick in the ICU. They want to go back to work. They want to go back to driving, playing golf, and doing their activities. And that's what our prime focus is. And what we do in the ICU can really, really help that what we call trajectory or those outcomes.
But I remember one night in particular in the ICU when I didn't know which end was up. I mean, I just had this general remembrance of this, where they were coming to me, they were just trying to comfort me. It was everything from me saying to them, I am having a difficult time breathing, to where am I and everything else. And so, at that moment, I think I qualified as somebody experiencing the delirium that you're talking about.
I think you most definitely did. So if we could recognize that, there's the, we could treat the symptoms, we could reassure you. And some of the big changes, like in this ICU bundle I'm talking about, where we do it, it's called the ABCDEF bundle. Okay, A is for pain, B is for breathing and trying to get you off the breathing machine faster. C is drugs and light sedation, but it means reducing drugs like Valium type drugs. D is recognizing delirium. E is moving and exercise, even while you're still in the ICU. And F is family. And I think that's a really important thing. So here at the Brigham and Women's Hospital, many ICUs around the country, we've had to step back a little bit with COVID, but we're bringing patients' families back into the ICU. And so our families participate in ICU rounds. Patients are at the bedside, and we give families meaningful things to do with their loved ones. And one of the biggest things is that families can recognize things. They know, they have obviously a close relationship, so they know what the baseline status and condition was. They know how their family member likes to sleep, what they might be trying to communicate when they're on the breathing machine, because that can be tricky. And it's such a reassuring thing because a patient is in a very foreign, just like you were at Hopkins, setting with an ICU and people all gowned up and lots of machines beeping. And if a family member's there reassuring, holding their hand, doing things, it makes all the difference in the world. And even during COVID-19, we had families that we would phone them, and sometimes we do it on video, where they were actually engaged in the rounds with the doctors and the nurses and the pharmacists and everybody else. And so this really, really helped provide information to the family in real time, where they could ask all kinds of questions and they'd really understand what's going on. We used to sort of feel, well, most families can't really handle the information. We want to put the family in a bubble. They're in a stressful time. But we've done a 180 with that. We realize it's very, very stressful for families, and we do have a lot of support for families that have patients in the ICU. But it's better that they sort of see the real thing with that support and be engaged with their loved ones, rather than, sort of separating families and then they find out everything after the fact. So we use our families, we engage them, and we really are starting to show much better outcomes of that. And then the other thing we're doing is we run clinics. So we call this PICS clinics, but it stands for post-intensive care syndrome. And these are patients that are struggling with their recovery. So they've survived their ICU stay, but they're struggling with how their brain works. They're struggling to use their iPhone maybe. They might have signs of depression when they didn't have depression before. Some patients will get, as soon as 4 weeks after an ICU stay, they can start getting, I'm sure you've heard PTSD, where they have bad dreams and memories and anxieties from the ICU stay. So we have therapists and a whole multidisciplinary team thinking about these symptoms. It used to be, when we worked in the ICU 15, 20 years ago, people would be sent out and we'd never hear about them again. But now we're totally connected on that trajectory of patients, families, and really making sure they have the best recovery possible, which is just so important.
John, what you were talking about, the involvement of the family, if I'm not mistaken, you're referring to this, I guess it's a whole brand new medical movement, going back to the future, the patient and family medicine concept, where, doctors are really listening to the patients and the families more and getting them involved in the whole process, which I guess just delivers a better medical product overall and better outcomes.
Absolutely. It absolutely. And we're starting to get really good data to show that. We've always known, I think, in our heart as clinicians, that that's the right thing to do. And there's things, you can't always get numbers and evaluate everything. We just know from our experiences that this is the right thing to do, and everybody wins, right? We win as professionals, the patient wins, and certainly the family's the biggest winner, I think. And also at the same time with all of this, kind of, I just like to touch on your important roles. And is the importance of family members and ICU survivors in really helping inform what we do in the ICU. And you were involved. You played a critical role, Ed, in the Society of Cochlear Medicine's pain, agitation, delirium, mobility, and sleep guidelines that I chaired. And these guidelines, as you remember, were a whole series of sort of Zoom calls where we would talk about the data and making recommendations on different things. And I don't know if you remember, there was one call, Ed, where you were on, and it was focused on sedation. And we were talking about the importance that patients always be lightly sedated and never deeply sedated, which I was kind of describing before. And, you had all these top experts on ICU sedation that had done tons of research. And you put up your virtual hand, and, which was really interesting. And it stopped everybody. People were silent because what you said was, no one ever asked me as the patient about the level of sedation I would like to have in the ICU. And, many days you might want to be lightly sedated so you can engage with your family and know what's going on. But I remember you said there was one day that you were just having a horrible day at Hopkins and you were just exhausted and you wanted deeper sedation. And no one asked you, did you want deeper sedation? And so we actually wrote in our guidelines, ask the patient, if possible, about the level of sedation they would like. It doesn't mean that we're always going to give deep sedation, but we need to ask our patients a lot more. And there is ways to find this out, even if you're sick in the ICU on a breathing machine. So this is just one example, and the list goes on. And our patients were such a key part of this. We learned so much from them. And in no way, shape, or form are patients just sort of part of this to make it look good that we're saying, oh, we had a patient. The stories, I could go on and on for an hour about the stories about how you really helped inform our guidelines with all of your experiences. It's a really, really big deal. And then, with medical research, we're always listening to our patients and their families about medical research. And that's why Ken, you're involved in a large North American study with Karen Burns at University of Toronto, where we're looking at how aggressively and how fast to try people, because we have to do what we call wean. We have to do tests when people are on mechanical ventilation on the breathing machine to see if we can get them off. And you're playing a key role in that. We're trying to do it faster or more often. But I remember one point you brought up is that there's some days patients just don't feel like being awake and having to do all that work 2 or 3 times a day. So, we're listening to families and patients about what are most important research questions and how we can really make sure our research is of the utmost potential benefit to patients and their families. And, there's no medical research that anybody does anymore unless there's, the benefits to the patients and potentially to the families are greater than any potential risks. And that's something that we really, really focus on, even in the COVID area, with our research. And so this is just another really important thing I wanted to mention about this really important role.
One of the things that I remember from that first study that I worked with you on was the first time you or somebody on the team asked me a question. And, I'm thinking to myself, okay, I'm an educated person in the area of education, but what do I know about medicine? I know how to put a Band-Aid on. But you asked the question, it went something like this. If you're in the ICU and we have the opportunity to take you off the ventilator early, do you think that your family would want you to come off the ventilator early? And I'm thinking to myself, are they trying to trick me? Are they trying? Do they really want to know my opinion? And I simply said, well, if it's medically warranted, the patient would love coming off the ventilator early, and so would the family. And then after I gave that answer and I saw that it was accepted by, if you will allow me to say, all the medical gods sitting around the table, then I thought, okay, they really do want to hear what I have to say as a patient, as a survivor of the ICU. So, and for people who are watching right now, if you ever have the opportunity to get on a research team as a layperson, then I advise you to do so, because not only will you be helping other people in the future, but you will learn a lot. You will learn a great deal. So
yeah,
John,
and I would also just not to interrupt that, I'm sorry, is the other thing is to, if you happen to have, the unfortunate situation of one of your loved ones, if any of the viewers have a loved one that ends up in an ICU, think about these things and it's okay to ask these questions, that what you're seeing and perceiving is, I don't think my loved one's comfortable, or if the ICU physician or nurse, whoever you're talking to, is communicating you a potential plan, it's okay to ask questions. It's a courage. So if you're, it could be that you just don't understand the terminology, but it could be bigger things where, there could be some potential benefits of doing something, but there could also be some risks. And it's really important to understand what are really the benefits and what are the potential risks. So it could be a new procedure or something, but it also could be things like how fast you get off the breathing machine, like you suggested, or other supportive therapies. The list goes on, but it's okay to ask about these big picture things and think about them, and don't be rushed, because these are big decisions. And, there's urgent things that happen in the ICU, but most things there's time over an afternoon or an evening or a day to be really thinking about some of these things. And it's okay to also engage with other family members or other people that with medical experience to help inform some of your decisions as well. So the ICU team really wants that. We love when family members that are making decisions for patients, sometimes patients can make their own decisions, but often it's a family member. We love when people have had good discussions and it's been helped by, it could be anybody, a friend who's a healthcare clinician, it could be someone from the clergy, a friend that they know that's good at thinking about through. We love those informed discussions. That's really how the best care is delivered.
You see, I remember when I was really, really young, when primary care doctors would visit the homes, and my mother and grandmother would spend about 2 hours before the doctor was scheduled to arrive to straighten up the home, because, of the perception that this visiting super person was going to come and visit, and all the honor and everything that was directed to this man who knew everything about medicine. And so I think that now time has gone on where now people have to get used to the idea that, you can engage this man or this woman. They're human beings. They need to hear what you have to say. They need to hear what your family has to say. They need to engage with you, because in the long run, what you have to say to them, what your family is going to say to them, is going to help you too, and help the doctor know how to plan, your health course in the future.
No, you're absolutely right, and that's the responsibility of the ICU physician and then the whole team around them. to have this engagement. And, I think most clinicians now, everything isn't black and white. We think, we have to make decisions based on complex data sometimes, and sometimes the studies that you've helped play a key role in informing, and the guidelines that I talked about that you played a key role in helping develop. But everything's not black and white by any means, and there's a lot of unknowns, and there's a lot of depends, right? And some of these depends really depend on I gotta say depend again, but it really is contingent on what the discussion is with families, and if the patient can communicate themselves, that could really drive a lot. And so I just, hopefully that's a message that's going to come through your viewers to make sure that, even in ICU care, or if they're offered to be put in, if they're offering to be participants in a research study, to really ask all the questions and think about this, because nothing's black and white in anything to do with the ICU.
Well, we're running out of time here, John. I told you this was going to go really, really fast. What I'd like to do is to twist your arm to bring it back another time where we can talk about the medical research and what patients should know about medical research before they decide to sign on the dotted line and say, yes, I'd like to participate in medical research and all that. But we'll save that for another time, perhaps, if I can beg you to do it again sometime.
Oh, it'd be my honor to come back. Thank you.
All right. I've got witnesses that you said that. Now, what I'd like to talk to you about in just a very quick, and it's so much to talk about in 2 minutes, but how has COVID played into what you're doing in the ICU?
Yeah, it's hard. There's kind of two situations. There's the surge situation, where ICUs get overwhelmed with patients, which is really, really hard. And in Boston, we went through a huge surge in last spring, and similar to your neck of the woods. And then we also went through a big surge over the holidays, December to January. And this is really hard when you have these really sick patients and clinicians are exhausted. We had to open up extra ICU beds to care for these patients. Of course, clinicians will do whatever it takes to optimize care. And then even without the surge situations, we just had no family. As I kind of already alluded to, we tried to keep families engaged on rounds and with their loved ones through, various electronic devices, FaceTime, etc. And they would participate virtually on rounds. But it really was hard. It was really hard for the patients, and it was really hard for us as clinicians not to have the families around. And because it's such an ingrained part of the of ICU care, and families just play such an important role. And we really, families support us, we support families, and it's a real win combination when we're taking care of their loved ones. So that was probably the hardest thing, I think, outside of the surge situations, is not having families.
Dr. John Devlin from Brigham and Women's Hospital in Boston, Massachusetts. We could have talked for another 10 hours, John, but the clock on the wall says it's time to go. I can't thank you enough. Thank you for your wisdom and guidance this morning. Thank you for being with me here on Point. Well, what can I say? I hope that I delivered, as advertised, a well-known medical research scientist here on this program, talking to you about what he does in the ICU, how families get involved, how they actually listen to patients and actually listen to families to bring about a better medical outcome. Dr. Devlin did say he'd come back sometime in the future, and we're going to hold him to that. And I can't thank you enough for being with me here today. Again, I appreciate your time. Thank you for visiting with me here on Point.